Welcome to Bear in Mind, the Brown Psychiatry Podcast, clear, current content about mental health. I am the host, Dr. Tracey Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm Dr. Camila, Cosmo, Psychiatrist and Co-Editor-in-Chief.
And I'm Dr. Au Yeung, Psychiatrist and Script Editor for today's episode.
And I'm Dr. Bob Swift. I'm an addiction psychiatrist, and I'm the guest for today.
First, a content warning.
In this episode, we will talk about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice. Today, we will talk about substance use disorders, a set of mental health problems that involve someone continuing to use a substance like opioids, cocaine, cannabis, or alcohol, despite negative consequences. According to the Substance Abuse and Mental Health Services Administration, in 2021, over 46 million people aged 12 or older, which is 16.5% of the U.S. population, struggled with substance use disorders.
Of those, 94% did not receive any treatment. Nearly all who did not get treatment at a specialized facility did not think that they needed treatment at all.
So to help us better understand these complex disorders, we are joined today by Dr. Robert Swift, addiction psychiatrist, researcher, and professor of psychiatry and human behavior at Brown, who has extensive experience in the field. It's our pleasure to have you here today, Doctor.
Well, my pleasure to be here.
Thank you so much for joining us. So what is a substance use disorder, and what are the most common types in the United States?
Okay. Substance abuse disorder there's a medical definition, which defined by the World Health Organization, or in the United States, the American Psychiatric Association, that has 11 criteria for use, to meet the criteria for substance abuse disorder. They include taking the substance, using more than intended, or using a lot of a substance. And the other thing is that there's a loss of control over the substance, that a person can't stop using the substance, and also uses it in situations that are harmful to themselves or potentially harmful to others, such as drunk driving. Mm-hmm. And then there are physical symptoms like withdrawal and craving that people experience. And these symptoms, which are biologically based, maintain the substance because the withdrawal is a very unpleasant syndrome that occurs. There may be anxiety and distress, and people will take the substance again to alleviate that distress, to make themselves feel better. Mm-hmm. And the craving is like a hunger to use the drug. It's an intense need to use the drug. You just think about it. Imagine if you're hungry all day and you haven't eaten, and you think about food, and you may feel symptoms. You might feel weak or something like that. And so substances have this symptom called craving. Substance use disorders have craving, which is much like hunger, and helps maintain the substance use.
Mm-hmm. And what are the warning signs of addiction? And why are some people more vulnerable to developing it than others?
Okay. Well, I think the warning signs are a person finding themselves in a situation where they are using too much of a substance. Mm-hmm. And it may be something they become aware of themselves, or it may be something that someone close to them, a family, coworker, a friend, may say, you're really using too much of this. Mm-hmm. Or it may be getting into a hazardous situation where somebody has developed an illness, like, smoking, which is a substance, nicotine. Using it can cause lung cancer. And, people may persist or have a precancerous condition and they continue smoking. So their healthcare provider may tell them, hey, you should stop smoking, but they don't, then they can't. So that's part of the problem with the substances. Now, who is more vulnerable than others? There are some genetic studies that suggest, we step back a bit, we know that substance use tends to run in families, but there's no one gene or one cause. In different families, there are different clusters of genes that make a person more vulnerable to substance use. It's not an absolute that says you have these genes, you're going to be become an addict, use substances to excess. But there are certain genes that increase the risk, and there are certain genes that decrease the risk. And we all have these combinations of genes. So they're actually genes that are protective. So, for example, about a third of people of Asian descent, Eastern Asian descent, metabolize alcohol a little differently. And when they drink alcohol, they produce a substance called acetaldehyde, and it makes them sick. It makes them physically sick. They flush, they sweat, and they get uncomfortable. And that protects them against drinking too much alcohol because they will start throwing up and feeling very uncomfortable. So there are many genes like that in the human population that both can promote the risk for substance use and protect it. But family history, nevertheless, is important. And if one comes from a family in which there is a lot of substance use disorder, it makes a person, these people seem to be at higher risk. And it's something a person should know about, that if one's parents, grandparents, aunts, uncles have substance use disorders, it's something you ought to keep in the back of your mind, that you might be at higher risk for developing this.
Right. So, Dr. Swift, how do you approach treatment of addiction in your practice?
Well, I think that it really has to be individualized. My approach is, the first thing is to understand what's going on, what's happening. Many people aren't always forthright with their substances, so it's important to do a comprehensive evaluation, and that includes both medical and psychiatric, psychological components. Understand family history, as we talked about, as being important, and use objective measures like lab tests, urine toxicology, things like that, to assess what might be going on. The second thing is to understand where the person is in their motivation to get treatment. They may be there for other reasons that aren't theirs. A court mandated them to come to treatment, or an employer said, get treatment or you lose your job, or a spouse or partner made an ultimatum. And it's not, they're not there for themselves, they're there for somebody else. And you need to kind of understand where they are and help them hopefully change so that their motivation for being there will be for themselves. And then finally is to present to the patient evidence-based treatments that work. Explain to people that we have a lot of treatments that work. There's not a treatment that works for everybody, but there are a collection of treatments that help people reduce substances, and then work with the patient to choose treatments that might be best for that individual.
So how do you address when someone has other mental health problems along with addiction problems, when they co-occur at the same time?
Okay. There are a significant number of people with addictions, with substance use disorders have, and we use the term addiction and substance use disorders kind of interchangeably. Addiction is kind of the general population idea, and substance use disorders is the official medical term. So you'll probably hear both in the course of the discussion here. Well, as part of the assessment that we do in the beginning, we try to understand if a person has a concomitant or a co-occurring mental disorder, because it's very important. People may get involved with substances because they're self-medicating another disorder.
Right.
And it may be a a lifelong disorder that they have, that they may have a psychosis or a depression, but it may also be situational, that something happened that made them depressed. The person lost a job, or they retired, and suddenly they have a lot of time on their hands that's unstructured, and they're bored. And so there are behavioral reasons why people might start using substances to alleviate some distress that they're feeling. And then there are the more kind of first-degree psychiatric disorders like bipolar disorder, schizophrenia, post-traumatic stress disorder, various anxiety disorders, where people will take the substance because it helps them cope with the symptoms of the disorder. Although it's not the best coping mechanism because it tends to be temporary, and then we can become dependent on develop a substance use disorder in addition to the psychiatric disorder, and that makes it harder to treat.
Right. When both of these things are happening, whichever came first, but they're now both present, you're seeing both present as the clinician. Is there a strategy of which one you should treat first, or how do you go about tackling both of these fairly significant problems that are happening for this person?
Yeah. Well, we usually treat both together because they interact with each other. And so it's important to, if it is a self-medication, is to eliminate the symptoms or eliminate the cause of the distress, which helps the person give up the substance. And likewise, giving up the substance is a rather kind of profound physiological stress. It's and psychological stress. It's hard to do, and that can trigger the emotional disorder, can trigger the psychiatric disorder too. So it's important to treat both together.
Makes sense. And how do you handle the stigma surrounding addiction when treating a patient?
Okay. Well, a stigma is a big issue, and it as in the beginning we're talking about how few people actually come into treatment, in spite of the number of people who have substance use disorders, and that is in part because of stigma. People are afraid. What will people think of me? And sometimes it's their job. If somebody's involved in security or certain types of professions, and they are diagnosed with the substance use disorder, and it's known, they may be ineligible to work in that profession. But that's usually uncommon. In fact, most employers like people to be in treatment, would rather have somebody in treatment and know that they are doing well rather than using substances, unbeknownst or, surreptitiously, secretly. So the stigma is important, and it's important to also emphasize that the laws actually give special protections for people who are using substances. There's a higher level, there's a level of medical confidentiality and privacy, laws such as HIPAA, et cetera. But in many instances, there's a higher level of confidentiality for substance use treatment. So people's knowledge is safe. There is this stigma. Many years ago, when one of the first treatments that was started was Alcoholics Anonymous, and there's some early pictures. People actually came to meetings wearing black masks. They look like the Lone Ranger, or or one of the Marvel superheroes, and because the stigma was so great, substance use has been destigmatized to some extent. There's now intervention programs on TV. A number of prominent individuals, politicians and entertainers have come out and talked about their struggles with addiction. And I think that has helped to destigmatize. And so those sorts of things are there. And then, of course, if somebody is really in recovery and is not using a substance anymore, they can't be stigmatized for it because they have stopped using and they're recovered.
And so you've mentioned a couple times about treatment. There's medication-assisted treatment, and then there's behavioral strategies as well. How do you balance those two?
Well, the best balance is to do both. And I think it's been shown again and again that one needs the optimal treatment for many disorders, for even a lot of medical disorders, involves behavioral psychosocial treatments along with medical treatments. Things like diabetes or asthma, they have a psychosocial component of education and psychological management and commitment to taking the medication, and all of those are part of the psychological treatment. The other thing is that the psychological treatments can help maintain permanent change even if one stops taking the medications. So, for example, certain types of therapy, cognitive behavioral therapy, is one type of evidence-based therapy, and it's been shown that so, for example, one could use a medication to target craving. I mentioned craving as that hunger to use drugs, and there are medications that can reduce that, but there's also psychological methods such as cognitive behavioral therapy that can help someone cope with this craving. Medication assisted treatment for craving depends on the medication. If one stops the medication or doesn't take it, that effect goes away. But the psychological effects may persist for long after one might stop the medication.
So you mentioned about like those medications that help with the craving. Can you talk a little bit more about that and let us know about the most common ones and how do they work?
Well, we don't entirely know how they work. One thing that the brain does is, and it involves a neurotransmitter called dopamine, and just about all drugs that are abused, misused, cause a release of dopamine in the brain. And the dopamine makes a person, when dopamine's released, it makes you feel good, but it also tells the brain that this is really important and you ought to look for it in the future, and that begins the cycle of causing craving, so that medications that relieve craving help turn off that dopamine surge that can occur even before you start using the drug. And then it tells you to start looking for the drug. So there are medications that, like naltrexone, that's an opiate antagonist. Recently, actually, I talked about the commonalities between hunger and craving, and one interesting finding has been that some of the medications to treat diabetes, semaglutide, which is known commonly as Ozempic, and there's a few others, reduce hunger. At the same time, they help diabetes, and people lose weight. And interestingly, it also reduces craving for drugs and alcohol. And it is interesting that some of the medications that we use to treat alcohol, for example, like naltrexone or topiramate, are also used for weight loss sometimes.
Right.
So there is a general effect of medications on decreasing this kind of what we call appetitive stimuli, that of needing to take things in. That our bodies our brains are set up to have this mechanism to take things in, food, et cetera, but also drugs, and so these medications can kind of tone down that hunger, both for drugs and in case of Ozempic for food as well.
Right.
Are there other medications that people should know about in treating substance use disorders that they may hear about from their primary care doctor or their psychiatrist or wherever they're seeking help?
Well, another big group of medications is substitution medications, so medication-assisted treatment. So in the case of opioids, people who are using pain pills and narcotics, one very popular common treatment is to give a person an opioid, but say in a safe fashion,
Right.
so that they take it under medical supervision, and it protects them from using street drugs, which might be dangerous, but also it can protect them from overdose by increasing their tolerance. So two very common medications used for in the treatment of opioids or substitution are methadone and buprenorphine, sometimes called Suboxone.
Right.
It's one of the trade names for buprenorphine. And those are increasingly and widely used. So rather than trying to stop people from using medication, from using substances, is to give them the substance, but in a safe, controlled fashion. And we speak about that as harm reduction.
Right.
That we're reducing the harm. We're not eliminating the harm, but we're using a medication to reduce the harm. And along with that medication comes psychosocial, psychological treatments as well, and those are mandated as part of the treatment. Sometimes vocational treatments and medical treatments, et cetera, for in the case of opiates.
So instead of time spent procuring the drug in a legal fashion and putting yourself at risk in a legal way, or also if you're using a route of administration for the drug like IV and putting yourself at risk for diseases, and also very significantly not knowing what is in the drug in the community and therefore overdosing or having it mixed with something which is quite lethal. This is what you mean. This is one of the things you mean by harm reduction.
Yes.
To decrease all of those risks in the acts of procuring the medication, procuring the drug and the substance, and you can get them in a much more controlled and monitored way. Okay.
Well said.
Yeah. So let's move on to cannabis, because this is another really hot topic that people are wondering about. And sometimes people hear things about cannabis that's conflicting, making it hard to understand ways that it may affect children or adolescents or adults. So the question we want to pose to you is it addictive? Is cannabis addictive? And how should they discuss this with their children? What should they tell them about cannabis here in 2023? What should we be doing as parents and as medical providers?
Okay. So the answer to your first question, is cannabis addictive? The answer is yes. Cannabis works in the brain much like other substances and causes changes in brain cells and brain circuitry. There's a withdrawal syndrome that occurs. And there are people who lose control over the addiction. All of the criteria for any substance apply to cannabis. One problem with cannabis is that because it was illegal for such a long time, there wasn't a lot of research on it.
Right.
It was very hard to do the research. I mean, in fact, it's still scheduled as what's called a Schedule I drug, which means there's no medical use for it, even though people are taking medical cannabis. But from the federal perspective, that's at the state level, which has legalized it. But at the federal perspective, it's still not legal, and it's you need special approvals to use it. So, for example, we're doing a study on cannabis and chronic pain at the VA hospital. One of the psychologists in the department, Jane Metrick, and I are involved in this study. And it's taken well over a year to get approval to get the cannabis chemicals, and this is not even with marijuana per se.
Right.
It's with the actual chemical components of it. So it's very difficult to do research, and because of that, we don't have a lot of knowledge, many studies are small, they're short duration,
Right.
And so we don't have the type of evidence that we would like to, in a sense, approve a medication. That being said, there are things that we know that now, two things that have happened in the cannabis from when I was in college a long time ago, and cannabis was I think was about 2% of the weight of the plant was cannabinoids, and now through selective breeding, it can be 70 to 80% of the plant is the active chemicals. So it's much more potent.
Right.
And in addition, the oils have been taken out and basically made 100% and are being used by vaping, which gets very high concentrations into the lungs and into the body. So the concentrations of cannabis that people are using, including children, kids, adolescents, are high, are much higher than historically we've ever used. And what are we finding? We're finding that there are effects on learning and cognition. There's concerns. There's actually on the developing brain, there are actually reductions in the thickness of the cortex, the part of the brain that makes us human, that helps us think. And there's reductions in how many brain cells are in there because they aren't developing. And that's imaging studies show that with human children, but in animal studies, they actually can show that in adolescent animals as well. And then the other concern is psychosis.
Right.
And so cannabinoids are what are known as psychotomimetic. They mimic the action of psychosis. And it turns out that the combination of cannabinoids in native marijuana has a good balance of, so there are two main components. There's THC, tetrahydrocannabinol, which is psychotomimetic, and then there's CBD, or cannabidiol, which is probably antipsychotic. And THC increases anxiety and can increase paranoia, and CBD reduces that. So typically marijuana had a balance in there. Cannabis had a balance, but the CBD doesn't make you high. It's the THC that makes people high.
Right.
And so a lot of the marijuana has been selectively bred for the high THC, and that can cause anxiety, panic attacks, paranoia. And there is preliminary evidence, but there's concern that it may bring out psychosis in vulnerable individuals. So if a person has a family history of psychosis, which might make them at higher risk to develop psychosis, they seem to develop earlier if they're smoking cannabis.
Right.
If they're using, and actually I should say smoking, because people ingest it as gummies and all sorts of things.
Thanks for checking the first segment of this episode. For more, check out part 2.